Thanks a lot for joining us again. It's a great honor for me personally to welcome Professor Paul Farmer to join us this morning. He is a great humanitarian, a great physician, and from the purposes of our conference, also a truly remarkable social entrepreneur. He's worked tirelessly to draw attention to the problems of global inequality, both in income as well as healthcare access, and has done perhaps more than any other person alive to work towards ameliorating these inequalities. To the extent that social entrepreneurship is the mobilization of resources to address a particular social problem, I think it's fair to say that Paul Farmer is one of the great living social entrepreneurs today. With that, I think, grand statement, I'll spare you the details of his many accolades and achievement, and instead turn the floor over to him. Thanks. Let's welcome Paul Farmer.
Good morning. It's not you're supposed to say good morning. Thank you. I actually do that in my own classes at a small community-based college in Cambridge, Massachusetts, that some of you know. And Ray, let me thank you. It's a daunting introduction, and admirable in its brevity, but daunting because I hope those things are true. I'm not sure that it's so. You know, why should one be so confident that work is making a difference? There's an obsession now, which I hope we'll talk about, with measuring with metrics. How can we apply some of the desire to quantify what some anthropologists have called audit culture? How can we apply that to the applications of new ideas? And I know that's what you're all struggling with, or I imagine that's what most of you are thinking about, having met a number of people in the room. So I wanted to just go back over some of our own experience as Partners in Health, but there's more to the story. Partners in Health is a 501, that's the legal term, 501c3. You know, it's a public charity in the United States. I myself have never worked for Partners in Health. I was the founding director, but I was a graduate student, like many of you are here, and then became a physician and professor at Harvard Medical School. And never stopped working with Partners in Health because that was the effector arm for a lot of the work that we were trying to do. And what I mean by effector arm is, if you have a Columbia University, you might not have an easy time convincing the university to go off and work in Mozambique. I'm sitting with a friend of mine who was in Mozambique this summer. And you can go down the list. Universities are very risk-averse places. Columbia less so than many. But they're designed now to do their research and teaching, and to a very limited extent, their effector arm work in the United States. That's what American universities are like. And I'm sure it's the same for French universities and Egyptian universities and whatever, right? That's the way they're designed. However, a lot of the work that you're doing, and certainly all of the work that I'm doing, or 90% of it, it crosses boundaries of the nation state. And so we really can't have global health without a global presence. So my students and the junior faculty who work with me at Harvard are also pushing these boundaries by living and working in places like Rwanda and Haiti. And then, on top of all that, if that weren't challenge enough, that is, reform these jewels of institutions, American universities, if that's not hard enough work, what about all the Rwandans and Haitians who themselves want to be trained to be effective, whether in medicine or nursing or business or small business management? So it's a very complex challenge that anybody involved in social enterprise across a boundary. I've mentioned boundaries of the nation state, but there are other boundaries too, right? There's boundaries of gender, class, language, religion. Anybody who wants to do that has got a very big challenge in front of them. And I'm here to talk about that and think about it with you. And I'm going to use examples, not because you should emulate them, but because they show some of these problems and also what can be done to respond. And just to go to first person, and I apologize for any of my own students or former students who've seen this, I went to Haiti in between college and medical school. And that year, in between college and medical school, was 1983. That should make some of you feel very young or just make me look old. I mistook Ray for one of the students when I came in. So 1983 was a really great year for me. I met some of the people that I'm working with to this day. Some have passed away of happily old age, others of young age. But these are the same people I work with. That number has grown and grown and grown. And it started in a way that pushed paradigms. I didn't understand this then. I was 23 years old. I didn't understand that one of the best ways to learn about the limitations of paradigms and economic models was in a squatter settlement. And you think about that. Here you are in a country that in the 19th century had more peasant farmers with their own land than any other country in Latin America. So it was a nation of freeholders, and we know about the history of Haiti and why they were freeholders and how they came to be freeholders or small landholders. And then, can you see in the background of this photograph, you see why they're squatters. I don't know how good the picture is. It's a hydroelectric dam flooded the valley. So again, if you were to say, let's create an artificial experiment so Paul Farmer can learn how to challenge his own paradigms of development, I'm glad some of you are laughing. It's not that early in the morning. If you were to do that, some economics professors do things like that, by the way. Let's create a natural experiment. Let's give these ones education and these ones none. Anyway, I got to warm you up before we can make jokes about economists. But if you had designed an experiment, an affectively laden experiment for me, it would be the best one. Go to a squatter settlement, figure out how to deliver health care for people who not only lost their land, but lost their livelihoods. Try your economic models on that. What's sustainable, what's locally appropriate tools, all the jargon and hypocrisies of development, some of it well-intentioned, they don't work in a squatter settlement. Because, what is sustainable over the long term in a place where people have lost, and not only they lost their land, look what else they lost. There's no trees. How are you going to grow the things that they were growing in the valley up on those hillsides? It's a very, very difficult situation. And so not being aware of it, I told you I wasn't aware. My Haitian colleagues were very skeptical of these grand ideas. Naturally, the Haitians are natural skeptics. I'm sure there are plenty of Haitians in the room today. And they were saying, well, yeah, whatever. But we would go out from house to house, my colleagues. And my colleagues, by the way, are young people my age, Haitian, and then Ophelia Dahl, who some of you know, is the director of Partners in Health. By the way, the young Haitians who work with me, one died in childbirth, one died of typhoid fever, and one died of malaria, of cerebral malaria, sitting in a physician's office, a psychiatrist's office, because she had presented with what were taken to be signs of mental illness. Again, it was a brutal place to start a squatter settlement and a very difficult time. People did not have access to basic services, even our coworkers. So the Haitians said, we should really build a hospital. And the health specialists at Harvard, now by then I'm going to Harvard, they're saying, oh no, you want a cost-effective, sustainable program that fits into, you've heard the drill. Again, it's what you learn in a graduate program. But don't be overly confident, and that's what I learned in these models. So we ended up actually trying to do too much, right? I told you already, there was no school. This is the beginning of a school. There was no clinic. We built a clinic, then a hospital. There were no trees. We planted trees. Looks like a very different place now. It's the same place, reforested. That's another thing. Again, I'm really hoping that I'll get a Nobel Prize for this astounding insight that the treatment for malnutrition is food, and the treatment for deforestation is replanting trees. But none of this is rocket science, right? And it's hard work. It requires partnerships. I'll be glad to talk about the kind of partnerships. I think they're obvious in a room full of people interested in social enterprise. You got to make partnerships with local people, but also partnerships with people in positions of leadership, people who can grow businesses and economies. To break that cycle of poverty and disease, as I was just saying to my friend Liz, it requires inputs from several directions at once. Healthcare, certainly, education, creating a climate for people to build businesses. And that business could be a mango processing plant or you go down the list. It takes a lot of inputs at once. It takes electricity, in my view. And here was a hydroelectric dam where everybody lost their land for a hydroelectric dam, and they lost, guess what, 2 things? They never had electricity, so they didn't lose it. But they didn't get electricity, and they lost their water supply. So there's also, often in this work, there's a history of, malfeasance in the eyes of the locals. Like, they felt wronged. They lost their land, they lost, anyway. So it was a great place to learn. And it's a great place to still be involved. And I am still involved there, although, this is a huge project. Some of you have been there, especially after the earthquake. This place became sort of a refuge for people injured in the earthquake. And although I was down in the earthquake zone, I was skipping ahead, going up there to see the patients and how they were being tended was very comforting to me 30 years after having been there for the first time. So here's our model. Again, not rocket science. Ready? You want to take out your pens and papers? Your generation doesn't even use pens and papers. So community-based care, again, this is what Partners in Health tries to focus on. We can't always focus because there's the water, the education, the food security, the job creation, the policy, the aid money that gets squandered in the wrong places. But when we can focus, we try to focus on this. We build community-based systems that create lots of jobs, by the way, for community health workers. We link them to clinics because most of care can be delivered in a home or in a clinic for, you name the major mental illness, AIDS, tuberculosis, diabetes, go down the list. And then we build hospitals because people, and again, newsflash, people do get sick. Some people are getting to enjoy my sense of humor already. And this is where we work. I won't go into this. We work with partner organizations. That's our MO, hence the name Partners in Health. And trying to be a university, also work with a university. We're doing research and training, as any university is mandated to do. You heard about the service and the effector arms. And then finally, we're trying to think this through. Say if you're working in Lesotho. Does Lesotho have a medical school? It doesn't have a medical school. By the way, the Navajo Nation doesn't have a medical school. I mean, a lot of the places we work, they have their own training needs, all of them, in fact, and we're trying to think about those too. Now, I'm going to use a brief example so that we'll have a rich discussion about funding, because I know a lot of you who are trying to move forward an agenda or an enterprise, you're looking, I mean, in some language, it's startup funds. It's not language that I'm familiar with or very familiar with, but it's the same problem when your goal or challenge when your goal is to build that system of community-based care, clinics, hospitals, and places that don't have them. And one of the ways that, one of the key examples that you've heard about has been through money that was allocated finally for AIDS. And this is something I hear from my students at Harvard a lot. Well, what if you're dealing with a problem which, unlike AIDS, doesn't have any funding associated with it? So our memory, our historical memory, is so short that we already think of AIDS as an overfunded area. That's nuts, right? People, I mean, all the time, my own proteges do this. They're like, well, what about, and then they'll fill in the blank with what they're working on. And they're working on good things, mental health, diabetes, you go down the list. Trauma, surgery, orthopedic mishap. But this is all recent history. And so what I say, and others do the same thing, is if it's a poor person's problem, it is by definition neglected, right? Poor people's medical problems, whether obstructed labor or AIDS or eye disease, ophthalmologic disease, whatever, they're all neglected. Chronic, acute, everything. So building these systems for people living in poverty is, in my experience, whether you're in Nepal or Haiti, a big challenge. And I don't want to go into too much detail, but as you can see, you take something like this focal OSI grant. That was a a grant to Partners in Health for $100,000. To my knowledge, the first grant ever made to actually treat people with AIDS with standard of care in resource-poor settings. It went to us in Haiti. And why would a little tiny grant like that be on this grand, slide that goes up to billions of dollars? And that's because you got to start somewhere. And that's what I think a lot of people in this room are interested in doing, is starting things that will endure. And I think even though I didn't understand what was going on in Haiti in 1983, I did feel that we should start something that would go on and last. And there are lots of pitfalls. One thing you need to do it is you need money. This is, of course, a before and after picture. I've shown this here at Columbia before, although not in this room. It's a patient of mine, of ours, named Joseph. Before he has, what two diseases does he have? There would have been a time when people in an auditorium like this wouldn't know. He has AIDS and tuberculosis. That's the #1 killer of people with AIDS. So he has a curable disease and a disease for which there's a good suppressive treatment, or was and still is. And what we did was deliver it through that system of community-based care. He was also sick. He was in the hospital for quite some time. But that's not, I ran into him not too long ago, years later, a decade later, and he doesn't get his care in the hospital. He gets his care from a community health worker at home. And that was the model we tried to get out there, because as you will recall, you long-memoried people who can think back 10 years, thank you. You will recall that people said, well, it's really not possible to treat AIDS in resource-poor settings, right? Remember all this debate? People have a different sense of time and culture. I mean, all this claptrap, That's why, by the way, that's one of the first times when I heard this claptrap, I was thinking, I'm glad I have a PhD in anthropology. Now it's coming in handy. I said, well, that's not true. I would hear things like, well, they have such a different culture. They. Who's they? As one of my students said, the Nazgul. They have a different culture, and they weren't even talking about a specific place. I said, well, yeah, there's a different culture in Berkeley, California, too, but we give them treatment for their diseases. That didn't really go over well, except in California. Long story, somebody's going to write the whole history of this, and I hope it'll be the true history. So we also use this money not just to help people, individuals, but to rebuild systems. And this is my colleague Jahan, who's here with me, will have seen. We saw a film last night of this place, which is broken down, fallen apart. And we said, well, we'll use some of this AIDS money to rebuild health systems, not just to take care of people with AIDS. Nobody said, gee, that's forbidden by the rules. You can't use. Actually, some groups did say this, but we didn't take their money. We said, you need this money to go to help patients, not just with AIDS, but with AIDS, tuberculosis, who need women's health, who need family planning. That was a bit of a stretch for these funding institutions. The good ones, the supple ones, got it, that you had to build health systems. And the Global Fund, for example. And that's what has happened. And when the better projects, Columbia has a number of, I'm just curious, how many people are here at Columbia formally as students or faculty? So Columbia has a number of programs in this arena as well, health system strengthening programs that were deliberately designed to build up capacity. And then we took the show on the road. Some of you have visited us in Rwanda, us being whom? If you take home anything from my comments, you heard a personal history of starting in a squatter settlement will teach you a lot, and that you need to think more integrated, not just the vertical programs, like what you might do. This is what I was talking with my friend Liz Stern about as we were sitting there. You can't just say, I'll do water, unless you have partners, right? Like that was the idea of Partners in Health. Someone else will do water, someone will do education, someone will do agriculture. But if you're in a squatter settlement, you got to find partners right then and quickly. Partners we forgot. That should be the name of this talk. Partners we forgot along the way. First 10 years, I don't think we did anything with the public sector. What's the public sector? The Ministry of Public Health. So we were doing what most NGOs and businesses do, and social enterprises, is we grow in a space that we regard as empty, social space, but it's not really empty. And I was among the worst of them. I would say, well, there is no public clinic here. And someone would say, yeah, there is. It's right over there. And sure enough, there would be a public clinic. And it would be closed, and it would have no staff and no supplies. And then we had to ask ourselves, well, how could we do this better so that 25, 40 years from now, you know, the rural Haitians, like the ones who we lost to malaria, to childbirth, and to typhoid, don't have to rely on the kindness of strangers. That's a really tough row to hoe. And that's, I think, where we are in a lot of NGO work. We're stuck because we haven't learned how to work with all the partners we need to. Some of them, but not all of them. Rwanda was a very bracing place to work because they actually said, oh, by the way, if you want to work with us, you have to work with us. If you want to work in Rwanda, you have to work with us. And some of the NGOs, I think, distorted that message into this is a manipulative, you know, heavy-handed state. There was one before the genocide, that's true. But I don't really believe that. I mean, they've been great partners. They're exacting partners. They're demanding partners. But they were right to do that because in the end, we had to bend to their will so that all those places rebuilt, including a lovely hospital, a picture I showed you a minute ago, we built them for the public sector in the public sector as an NGO. And that's in the jargon these days. These are public-private partnerships. And then we went back to Haiti, we never left Haiti, and did the same thing across the country. From the Dominican border in the town of Belader to the coastal city of San Marcos, we went in and said, okay, where's the public infrastructure? Oh, there it is. We're going to invest sometimes very meager resources into rebuilding it, painting it, fixing it up, putting in staff, and putting in supply chain, essential drugs, labs. Again, not rocket science. And on the eve of the earthquake, this is what the map of our work in Haiti looked like. And here, you know, this last point I want to make about the earthquake wasn't, and I understand many of you have looked at this book that we put together after the earthquake. This is not only a huge shock to the system and to us personally and to the Haitian people, but a very disruptive event for everybody trying to get work done. So some people thought, well, maybe this will be a reset button that will be good. That hasn't actually come to pass yet, but who knows what the time frame on a reset button is. I'm not confident I know. So eve of the earthquake, and then, I'm sorry, here is the picture I wanted to show you of this hospital, partnership hospital in Rwanda. I put it out of order. We opened a cancer center this summer. I bet this is the first, mark my words, this is probably the first cancer center where they actually treat cancer. What a radical notion for a cancer center. The first one in rural Africa. There are cancer centers, but they're in cities, very few and far between, and they're mostly available to people who can pay for the services. Not a lot of good insurance schemes, and very few for poor people. So this was, again, the fruit of partnership. You can see some of the partners. They're partners that we became accustomed to working with over the last decade. One of my former students is in the foreground, Peter Drobak, was in his hometown in Wisconsin a couple days ago, and I told people that all the Rwandans, I hope there are some Rwandans here. Any Rwandans? All the Rwandans call him Muganga Yesu, Dr. Jesus, because they say he looks like Jesus. I decided not to say historical Jesus, but anyway. Some of the other people you'll recognize. Now, where would we go on the training side? Just 1 second, and I'll go back to the earthquake. The training side is really tough, as I said. If you're in Rwanda, this is a picture from a few days ago, you're thinking about training Rwandan nurses and doctors and surgeons, and right? That's their job, is to worry about what's going to happen 20 years from now. And they've been pushing the envelope, as I said, by saying to everybody, what's your long-term plan so that we're not dependent on foreign aid by, what you guys know what year? 2020. So Rwanda has, for almost a decade, had what their business plan is called Vision 2020. It's to not need development assistance by that year. And they're thinking that way in medical terms as well. And so we're trying to train. Columbia is involved in this, Harvard, about 14 American universities and teaching hospitals are sending over, starting right now, up to 100 faculty members a year, not students and trainees like me when I was at 23, or many of you, but actually the faculty to go and train young Rwandan physicians and nurses to do the work that we were trained to do at places like Harvard. I think this is, as Clinton said, President Clinton said in announcing this last week, never been done before. It's never been done with this intentionality to a place like Rwanda rebuilding. And I would encourage all of you to keep an eye on it. It might not sound like some great innovation. It is. Now, this is, I've been thanking my colleague Jahan Setki, who's here with me, and I hope you'll be able to meet her and speak to her about this. One of the things that President Clinton has asked us to do, focusing on Haiti, but not only Haiti, was to look at the money going into Haiti and development assistance. Where's it going? Who gave it? Are the pledges really kept? Is it effective? How can we assess effectiveness? Again, this obsession with metrics is really important. So we've been doing that fairly quietly for 2 years, a little bit more than 2 years. And we learned a lot about what really happens. First of all, there is the phenomenon of pledges that are made but not kept. No surprise there. But that's only the beginning of it. And now we can track those. In fact, I believe, Jahan, that the tracking device, reporting device, is the only example yet of actually tracking disbursements after or before a natural disaster, and tracking them over time and showing, using this new, transparency platform called what is it called? The intertubes, the internet. I invented that, didn't I? Using the internet to say, hey, here's the pledge. So it's not been, again, that's shocking to me that no one did that before. So we're doing that. You can look on our website and as far as Haiti goes. But beyond Haiti, what about the big picture? So there's $150 billion in aid. And Ray has some familiarity with some of the international financial institutions, how they work and how they don't work. And again, it is not an arena that has subjected itself to close self-scrutiny. But we could do that. NGOs haven't either. And that's what we're trying to do, is not to play some name and shame game, which is not very interesting or gratifying to me in any case, but how can we make this better? It's a lot of money. In Haiti, there's probably enough money going into healthcare from private, out-of-pocket disbursements from families, including families living in poverty, and bilateral, that would be like the U.S. government to Haiti or the Norwegian government to Haiti, and multilateral, like the World Bank and the other IFF. There's a lot of money going into Haiti. The biggest challenge, I would say, if I had to pick one, is the implementation challenge. It's that there's goodwill, promises are made, some of them are kept, but then you got to make it work. And in a place like Rwanda, which amazingly has rebuilt some capacity to implement, you can get a lot done. Haiti has all the potential, the promise, and certainly has the people of Haiti, but the systems have been badly damaged, in part inadvertently, by NGOs who have done what Partners in Health did initially, which was to build their own. And we're even building our own food processing capacity in rural Haiti. So finding ways to be good partners, big challenge. And I think one that we can move forward in Haiti and elsewhere. These are just an image to remind me. I've actually brought all of this up before in the course of the talk. From fish farming to, I mentioned ready-to-use therapeutic farm to agricultural. There are a host of activities. This is kind of a food security slide. Host of activities that doctors aren't trained to do, much less subspecialist doctors, but they must be done, right? It just doesn't mean that we have to do them. We have to do them in partnership. And this is just my last slide to remind, pre-earthquake, to remind you that we got that. We understand that. You should understand it too. And after the earthquake, we had an enormous outpouring of support for Partners in Health. And all the NGOs that were Haiti-focused or had a strong presence of Haiti had the same experience. And one of the things we thought, because the health delivery infrastructure, I told you that the biggest problem was health delivery. The health delivery infrastructure was damaged or destroyed completely. The medical schools, the nursing schools, most of the hospitals. You guys probably know that the nursing school, the public nursing school collapsed. It was at 4:53 in the afternoon, so everybody was in their classrooms. And all of the students and their teachers perished. And that sort of event, I mean, there's not many other examples, but just imagine the impact that that would have on a system of healthcare delivery in a place as fragile as Haiti. So one of the things that we decided to do as a collective, again, linking Partners in Health to its sister organizations, Amis de la Santé, also linking the teaching hospital in Boston where many of us worked and other ones, Harvard Medical School, we said, you know, if we just scramble to keep up with the bad things what just happened, we're not going to get out of this trap, either as an institution or an NGO trying to support Haiti's public sector. We've really got to make a leap of faith. And this is the leap of faith that we made. And, you know, there's even odds, maybe, I hope not even odds, that people will say that they overreached. They can't do this. And we haven't shown that we can. I mean, one thing that kind of drove me nuts in the first year after the earthquake is there were all these charrettes. I didn't even know what a charrette was. All these models that people were making of new cities, new buildings, new hospitals, and I went to a meeting, I said, so many charrettes, so little action. There weren't a lot of implementation efforts. But we actually did build this, and that's what it looks like now. Now we have to open it. Now we have to run it. Now we have to remind people that it is innovative. It is a social enterprise or a pro-social enterprise to build a medical center in the middle of central Haiti. And I'm sure it's not going to be easy. I mean, we already know it's not going to be easy. It's not even easy in finishing the project. But we believe that out there, including out here, there are people who have the skills and the humility to help us move this agenda forward. So let me stop there and open this up to discussion. And thank you for including me in this wonderful meeting. Thank you. Ray, am I on time? Did I do good? The affable professor. Yes, please. And maybe if you could introduce yourself, I could remember. I see that there are mics. If you can't see them, I can see them.
I'm Laurel Eisner. I run an agency called Sanctuary for Families. We work with victims of domestic violence victims, many from many countries in South America, Asia, Africa, etc. I wonder if you could be a little more concrete and detailed.
A little more concrete than showing you a giant concrete structure?
Yes, precisely. About the comment you made that the problem is not the amount of money that went to Haiti, but problems of implementation, which were created in part, at least, by the NGOs. I mean, what does that mean in terms of what is it that happens or doesn't happen among and between all of the NGOs and medical schools and doctors and other kinds of rescue workers who do or do not work together?
Well, let me qualify a little bit. I didn't say that the problem was this and not that. I said if I had to choose number one problem, it would not be that the amount of money pledged is inadequate, although it is inadequate. I mean, if you elevate health, education, social services to a high enough level, immediately you're going to see that even the pledges are not adequate for 10 million people. Okay. So that said, the implementation challenge is a big part. Now, I want to be careful making claims of causality about NGOs. I work with one, as you know, or two or three, And I happen to know that the motivations of people in the NGO community are impeccable usually. The issue is one of coordination with other broader social goals that are held by the Haitian people, including people in something like a Ministry of Health. And I'll just give a number that I would be glad to elaborate more on in concrete detail. Of the money that went from the United States to Haiti after the earthquake, there's a very large amount, in the billions. Less than 1% of it went through the public sector. So 99% went to NGOs, contractors, the military, US military. And I'm not saying that that number, that I know what that number should be. Should it be 50%, 60%, 70%, 20%? I don't know. But I know it shouldn't be 99%, because that's the mechanism that creates competition between NGO contractors looking for the resources rather than coordination and collaboration. And to switch to the less freighted topic of Rwanda, when we announced this training program, I'm glad that someone else from another university said this, that these are our physicians. He got up and said, you know, before this program, Human Resources for Health it's called, which takes US money and gives it to the Rwandan Ministry of Health, as opposed to the contractors or the universities directly, for a very low overhead to the Americans. And he said, the faculty member, before this we used to just compete for these dollars. This is the first time we've ever really collaborated to build a consortium to do medical education in Rwanda. And I thought it was a very telling example, and there have been efforts like that in Haiti. I just think we need more of them. And that way, it's not building the highest density of NGOs in the world today, which Haiti and or India are said to have, but also helping build long-term infrastructures, even if we ourselves, like your group, Sanctuary, like PIH, are primarily focused on remaining nimble, non-governmental players. And again, if you were to compare your budget to the budget of Division of Youth Services or something in New York, your budget would be tiny compared to theirs. That wouldn't be the case in Haiti. At least half dozen health-focused NGOs have a larger budget than the budget of the entire Ministry of Health. And there are a couple NGOs that have a larger budget than the Republic of Haiti. So these distortions are being felt all the way out to the level. And again, one last thing, I don't like being a critic of this. It's not a fun thing. It's much better to be, Mr. Jolly Doctor, but it's a pathology that the Haitians are underlining again and again. Can I tell one anecdote? I am lucky enough to work with a group of, the term used in Haiti, thrown around all the time, is orphans. Not entirely clear that most orphans are really orphans. I'm sure you know this more than most people. But they're kids with serious handicaps who were unaccompanied minors in the hospital on the eve of the earthquake. So they had serious mental or physical handicaps. They were basically orphaned by disability. And they were in a very difficult situation. The Haitian public authorities didn't want them there, but they also wouldn't abandon them. So there they were, stuck for many of them for years. So anyway, we were involved in moving them to a safe place, building up a kind of oasis around them. Now it's a small number of kids. And there's a Canadian couple who's been supporting this work. And I ran into them in Port-au-Prince the other day, and they said, oh, we've been to Sami Beni, that's the name of this place. And I said, oh, how are the kids? They said, great. We ran into one of them, a kid about 4 years old who I know, and they said, well, what do you want to do when you grow up? And he said, I want to run an NGO. Now, I submit to you that is not a normal thing for a 4-year-old to say. Please.
My name is Spencer Taylor from Launch.com, and I was wondering, I have a friend who's studying the transmission verticals for HIV within Haiti that you guys have been working on. I was wondering if you could talk to specific challenges with that, and also how, in terms of the pedagogy of what makes up kind of the social factors that impact your work in talking about AIDS and HIV within Haitian culture, and how you navigated that and how you see that being replicated in other countries with similar kind of traditional roles that make it challenging to bring up conversations about sex and sexuality.
Yeah. Well, transmission verticals is highly arcane language probably for a lot of people here. To study transmission verticals would be, just if I may, to say, okay, how much of this is due to mother-child transmission, how much is of the, in other words, parse out the relative contributions of various factors in the transmission or retarding the transmission of HIV. And I would just say that, and this is a more sophisticated area than I've followed in the last decade, but when I was studying it back in the 90s, it was a very rudimentary discussion for precisely the reasons that you said. People were unable to understand the social determinants of HIV, and they were able to name things like cultural contributors. But here's an example of the kind of thing that the unsophisticated back in the 90s analysis was doing. They were saying that what were really gender inequality and poverty, they were calling those culture. I don't think there may be a culture of poverty, or there may be a culture of gender inequality, but they in and of themselves are social determinants of risk, not cultural results of risk. And so that debate was very difficult, I think, in the public health circles, especially in implementation circles. Because, if you want to prevent transmission of mother-to-child transmission, it's fairly specific and not that difficult to do. But preventing gender equity actually requires taking on poverty, taking on job creation, taking on land tenure, taking on legal rights for women. And it's a much more, some people would call it a much more upstream set of interventions. And a lot of people, not me, but a lot of people are afraid of that work. You're not, we're not. It's just that it's hard to quantify, identify, scares some people. It doesn't scare the people who are living on under the heel of poverty and gender inequality. They want us to acknowledge those factors, in my experience. So just the last thing I will say, how does it work into our work? I assume you mean the effector arm work, the Partners in Health work. I would say not great. It's very, I'm not going to say, gee, we've got this down, we know how to address both the medical needs of people, like surgery, and also the upstream social determinant needs. I'm not going to say that. What I will say is we care a lot about it, and probably through job creation, we've had a very significant effect on the upstream risk. But how much of our program can really be moved into the very hard and expensive work of altering social determinants of disease? Still a big debate, I imagine. Again, I mostly followed this in the 90s. That's when I was writing about it and studying it. But I'm passionately interested in it. I know there are people here and in other universities who are trying to figure out how can we do that? How can we both? And here's the language I use with medical students. It's your job, medical student, to prevent the embodiment of racism, gender disparity, et cetera, as high rates of disease or bad outcomes. That's what the job you've signed up for. There are other jobs, too, that are important, and that is to prevent racism and poverty from repeating, and gender inequality from repeating in generation after generation. It's a really grand societal project that a lot of us are signed on to. Thank you.
Hi, my name's Santiago Perez, and I'm the founder of the Community Alliance Network. We do work with providing legal and medical support to sexual violence survivors in Kenya. And what I'm really interested in is sort of, if you could speak a little bit to the model of Partners in Health, in that what makes a good partner in health? Like when you're looking for a sister organization, what do you look for? What makes it excellent?
Again, I'm just having this conversation with a friend of mine on the way in. The ideals of a good partner in work like what you describe or what I describe, I would say it would be a group that is not determining their mode of action solely by funding streams, by what's available. Again, this gets back to the challenge that NGOs face. NGOs are in a tough situation too, right? This contracture of the economy is felt, I think, pretty briskly in philanthropy and in NGO work. So you need to find mission-driven partners who will say, here's what we're trying to do, and here's how it complements your work. So mission-driven, complementary. Another thing that I see that's very rare, and I'll just give one example so I'm not up in the air, is when we wanted to solarize our facilities, which again, mostly public sector facilities, right? We tried to make that switch so that of the 70 or so hospitals and clinics with beds that we run in the world as Partners in Health, we do it with the ministry, and many of these are owned by the ministry. So we wanted a partner who could solarize these, who could do the technology, but who would also not treat us like a client, even if we were bigger, right? So a number of the groups we reached out to, they just wanted to regard Partners in Health as a customer. I thought, well, why should we be the customer? Why should we be responsible, more responsible than you, when your mission statement is to bring clean power into the world? Our mission statement is to make a preferential option for the poor in healthcare. You do it. You both do it and find the money for it. Love, Paul. And believe it or not, we found a group who took to that kind of shellacking as if from a Catholic grandmother. And, you know, we've done all over the world. The group is called Solar Electric Light Fund. And we've worked with them in Rwanda, Burundi, Lesotho, and Haiti. And our main implementing partner, an American who was, you know, who worked in all those sites, he was killed in the earthquake. He was there at our request, helping us to solarize, you know, some of our work there. And he died in the earthquake, like a lot of our friends did. And that's not the important part of the story. The important part of the story to us and to his family, of course, is that. But there's also something, I think, very beautiful in thinking about, his name was Walt Ratterman, is someone who believed in the mission, in the complementarity. It worked with a group, Solar Electric Light Fund, that took the responsibility for finding the resources to buy the panels, to put them up there, and then to train local people to maintain them. And to my knowledge, they're maintained. I mean, I was there the other day. I don't want to look at the solar panels and see if they're working. Why should I have to do that? I mean, solar people don't know how to diagnose infectious disease or dose antibiotics. So that's the partners that I would look for. They're mission-driven. They're complementing what you do, which is difficult work, difficult enough. They are not going to treat you like a client, but like a real partner. And they're willing to accept responsibility for a chunk of the work. Hardest thing to do is find partners like that. You know, they also have to, you know, get along with people. I mean, that's what partnership's about. Partnership's really hard, but that's who to look for. Did that help at all?
Yes, thank you.
Thank you.
Hi, my name is Jason Rosenberg. I'm the co-inventor of a low-cost medical device for PPH, the leading cause of maternal mortality. My question is,
wait, I invented that. You didn't invent it.
what are the problems with adding a new technology to international health programs?
Yeah. Well, it's a great question, and I think that when you build systems, health systems, right, where you are going, in other words, you can take vertical money. I liked how we're using it. Only at Columbia would you use vertical, horizontal so freely. You take vertical money, and you invested in building systems. And I mentioned that a system that we're trying to build, you know, which I hope we're doing okay at, goes from the community to the town, a health center, to the bigger town or city in the hospital. You take PPH, and any complication of, especially a third trimester complication of pregnancy, leading cause of death, as you said, and that was probably the leading cause of death of American women 150 years ago, right? Not PPH particularly, but complications of pregnancy. So you take a new technology, if you don't have the system built, if you're all, back to the partnership question, which I think is a great question, if you guys are guilty of the wrong kind of partnership, I think it'll look like this. It'll be, we're here, we have a new technology, you deal with everything else. That's not what the solar guys did. We said, yeah, it's your technology, you come in, we have the systems, but you put it up on the walls, you implement it, you deliver it. I think it's the same thing with the technology. Inventing it, if you're inventing it for poor people, it's not enough just to say, hey, here, give us a patent, we'll give you this gizmo. That's what you can do if you're inventing, the iPad or the iPhone. There's huge demand that is felt in the market for iPhones, right? They're fantastic little things. People buy them like hotcakes. Actually, they buy them a lot more than hotcakes. I've never seen a hotcake sold on the market. But a device to help save the lives of poor women, there could be big demand based on the burden of disease, but no perceived demand because there's not a market. And I'm just saying a really good partner will try to work that through responsibly and help the people who build the systems and deliver the services on the ground and help them incorporate a new diagnostic. When we got better diagnostics for HIV, we actually had people come from the company and they said, oh, here, buy this thing. We did. But we said, do we really have to learn how to service this? And can't you help us? And, those are the kind of partners that we need when we have new technologies. We'll build the systems, or systems will be built. My English teacher in high school said, never use the passive voice, but I like it. Systems, they will be built. And then you bring in a new technology that can help people, and you and your colleagues, take some responsibility for helping us hapless implementers to incorporate it if you're confident it will save lives. We'd love partnerships like that. And that's really just more of an answer to your question as well. But I'm going to say thank you in advance, having seen many women die of third trimester catastrophes. I don't want to see it anymore. And we built platforms to make sure that surgical deliveries are available. We build platforms to make sure that we have family planning, that women's health agents can reach up to. We need more tools in that and more support for the system. Thank you.
Hi, my name is Chris McKee, and I'm a current business school student. But before business school, I worked for the Clinton Health Access Initiative within the Human Resources for Health team.
Never heard of it.
In Zambia. But going back to Haiti, I wanted to ask, what has Partners in Health done, and maybe other NGOs done, to build government capacity to run their health system? So for example, once the NGOs pull out after a couple of years, what have you been doing to build their management capacity so they can help and make sure that all the progress that's been made is maintained?
That's a great question. I actually think CHI, the Clinton, then HIV/AIDS Initiative, and now the Clinton Health Access Initiative, is really the leader on this score. And this is back to the model that I mentioned, the first, some of you know, and some of you know well, I'm told, Ira Magaziner, who's really been, along with President Clinton, the visionary on this. When Ira and President Clinton decided to take on AIDS, it was precisely because it was a huge problem and neglected. And what part? Not the transmission verticals, but, I love that term, but rather the treatment. There was nobody doing treatment. And the medications were not available. And they came to visit us in Haiti, actually the first trip that Ira made to look at a treatment program. He didn't have many choices. He had to come to Haiti, and he did. And we were working, we just initiated our public sector strategy. So we moved into the public clinics. This is more than 10 years ago. Now, to your point in question, what are we doing to help on the management side? I heard you. And I would say it's just now, and this project that I mentioned, which is also a CHI project, the Human Resources for Health effort, is much more consciously focused on medical care at the request of the countries, on nursing training, but also on management. And we've tried before, lots of us, Partners in Health, CHI, many groups have tried it, but I think the investments have been inadequate, because you'll say, well, we'll send over our trainees, but they didn't really ask for us to send trainees. They asked for us to send people who actually can help, but it's not saying they weren't good hosts to trainees, but they really were looking for people who could do the management and train their own trainees. And I think that's really happening now. So case by case, you'll find in some places, and I'm not familiar really with Zambia, but case by case, it's worked really well in some places. Rwanda, where I've been working, first of all, they've been teaching us, the Rwandans, about management. Second of all, they're building up with great intentionality their capacity in delivery, of course, that's what we work with them on, but also in training and management. So I think there'll be a lot of progress in the next few years. Thank you. I was told I could only take one more, but I'll stick around as long as Ray doesn't kick me out. Where'd he go? There he is. One more?
Okay, sure. Hi, everyone. My name is Gerald Mcelroy. I'm here at SEPA in MPA program and development, and also head up a development team for a small NGO in the Dominican Republic that works with Haitians called Hispaniola. Paul, I wanted to ask you about two discouraging realities that I saw in Haiti during my time there with NGOs that I think are very different from the model of Partners in Health. One, very extravagant expenditures that are justified by security in places like Pétionville, where you see NGO workers, not living the simple life. And then the unwillingness of a lot of NGOs to invest in Haitians in the way that Partners in Health does, looking for a sustainable strategy and wanting to empower people as opposed to creating more cycles of dependence. How has Partners in Health dealt with other NGOs like that? Is it difficult to partner with others that don't share the same vision that your organization has?
Well, first of all, thank you, and thank you for your decade of engagement or more with Haiti and Haitians. I want to sound a note here of self-criticality as well. I don't think that we have lived up to our own aspirations. But we have done some things right, I think. And that is one of the best ways to empower Haitians is to make sure that they get the jobs. Because the amount of money going in through NGOs is very significant. And, they should be good jobs. And a community health worker job is not a very good job, right? But they're jobs. So I think there's been and this is going to sound very, neo-Marxian, but the amount of capital transferred just into households through salaries, however wimpy, has been significant over the last 20 years. I think we should stick with that. Mm-hmm. Is it hard to partner with other NGOs? Sure. Partnership is hard, as I said. And one of the things that I'm encouraging, and maybe when I talked to you when you were in high school, I would have been a little bit more fiery about this. I feel less passionate about it, but I think that it's important for a group that's been there a long time, 25 years, to temper critique, to focus a little more on self-criticality and try to bring other organizations, NGOs particularly, into work like this, because it isn't easy to do. So why should we temper it? So that we can not just win an argument, but actually, win the battle to make ourselves and other NGOs function better for Haiti and for Haitian sovereignty. And that's what whenever I feel beleaguered or criticized about something like that, I really am able to say with a straight face, talk to my Haitian colleagues. They run the program. Not me. I haven't ever really run it. And I've been working on this for some years. I've been working with Jahan and others and President Clinton and others on a policy level, and also working in Rwanda. So that's one thing I would say is you gotta if you're committed to partnership, you've got to bite the bullet and try to be better at partnering. And it's not something that all of my coworkers, especially my American coworkers, they're fervent about this. They care about it. But we've got to get better at saying, okay, well, we're not perfect either. Let's see if we can move this agenda forward. And I try to give a couple examples, like the example, CHAI is a good example of a partnership organization. The solar people, they were good. And can I tell you one last story that will really, so you also meet unlikely partners. And maybe I shouldn't say this in front of hundreds of my closest friends, but in helping those children with serious handicaps, I'm told the word now is intellectual disabilities and physical handicaps. Although I know a number of people who could be similarly described on the faculty of Harvard. But, so, these are really vulnerable children, right? And it's very hard, it's very hard to do this work if you're not an expert, you know, and there's all kinds of pitfalls. You've read about them. You have in Haiti and elsewhere. One of our best partners has been a group of evangelicals from the United States. And at the same time that their leader was making, in what sounded to me like kind of cockamamie comments about why the earthquake happened, the people on the ground were terrific partners to work with. They always showed up. They showed up on time. They took their responsibility. We'd say, help us with water. Help us, you know, find this place. Help us, you know, buy it and make it safe for these children. And, you know, I point to them all the time internally in partners in health discussions, say, listen, if we would have dismissed them as somehow not aligned with us, we would have missed out on a really great partner. And it's avoiding that reactionary stance of dismissing people because they set up their NGO wrong, or their headquarters are in Pétionville, or they have, you know, it's a tough thing to do. But I think we should all try and do it more. Well, I'm going to hang around. I'm told that I have to close. I'm not going anywhere. I apologize for not having shorter, more concise answers. It's not my strong suit, but I'm going to stick around. Thank you very much for having me here.